Pleasure to introduce the next speaker, who's a dear friend of mine, Dr. Aqeel Saleem, consultant infectious disease at Tawam Hospital and program director of internal medicine residency, who will be talking about updates on inpatient, outpatient management of COVID patients. The floor is yours, Dr.
Yeah, Assalamu alaikum all, and Assalamu alaikum. Good afternoon. So as we see, the topic is very broad and the time is very short. So we'll just do very quickly. Yeah, sure. Do we have a pointer here, or we can here this one? Okay. So as we see, the topic is very broad and we have short time, so I'll just go very quickly. So I'm presenting updates on inpatient, outpatient management of COVID-19 patients. So the objectives for today is the use of antivirals for mild, moderate, and severe COVID infection, dexamethasone role, updated guidelines from DOH and Dubai Health Authority, a role of sotoraslimab, and there is a need of frequently updated guidelines as we go along. So Dr. Jihad already discussed these kind of viruses. We hope we are not going to go there, reach omega. So introduction to coronavirus mode of transmission. Now it has been recognized through CDC, WHO, and all the authorities that coronavirus is a large family, and we see a lot of coronaviruses. For example, if you go by respiratory panel, you will see a coronavirus, and that would not be a COVID-19 virus. And in people with coronavirus illness, ranging in severity from very severe to mild range, like asymptomatic, just viral shedding. And also, it's a kind of a virus which is in humans, and there are, as I mentioned, a lot of viruses. The estimated incubation time is up to 14 days. And possible transmissible routes are contact, droplet, airborne, fomite, fecal, oral, bloodborne, mother-to-child transmission. Contact and droplet transmission is the most common way of transmission. And clinical signs and symptoms, I think by now everybody knows that what are the clinical signs and symptoms. Fever, cough, chills, headache, myalgias, runny nose, sore throat. And I think just one important thing that would differentiate between other viruses and this would be loss of smell and loss of taste. So morbidity, this is very important actually. The morbidity, 10% of require hospital admissions, and amongst those, 10% would require ICU admission. We have seen a lot of patients who are going to from floor to ICU very rapidly, very rapid deterioration from the floor to ICU. And mortality, how do you define the mortality, and how would you figure out that the patient who is just mildly symptomatic is going to become symptomatic? That's the age group and the problems that the people have usually, the like hypertension, diabetes mellitus, immunocompromised status, and these people have a lot of tendency to go in multi-organ failure. So complications, actually, this virus can infect any part of the body. So it's probably one of the unique viruses that can cause severe pneumonia, acute respiratory failure, ARDS, acute renal failure, DIC, disseminated intravascular coagulation, sepsis, septic shock. When you see a COVID patient, an outpatient and inpatient, probably the minimal things which are required, which we do, this is a clinical, your clinical modality, that whether you want to do these tests or not, would be CBC, renal function test, random glucose, LFTs, CRP, chest X-ray, and ECG. If the patient is positive and has mild disease, then you want to do CBC as mentioned. Then you want to do a few more tests like CRP, procalcitonin, LDH, D-dimer, which we discussed that it might increase mortality due to high coagulation and due to thromboembolism. Troponin creatine kinase, as it can affect the heart and kidneys, pro-BNP and pregnancy test should be done because there are some medications which are potentially teratogenic. So these are the recommended guidelines from the Dubai Health Authority and from Abu Dhabi. How do we diagnose? We should take deep respiratory samples, sputum or deep tracheal aspirate, or nasopharyngeal aspirate, swab, oropharyngeal swab. Now these days it's been recommended for the children under 10 years of age, under 12 years of age, that we usually do buccal swab or saliva testing for them. For intubated patients, of course, it would be a deeper sample is more useful. You can also check for atypical PCR panel because sometimes you are treating COVID and COVID is there, but then you are missing the other lines like Legionella, Mycoplasma, AFB, cultures from TB or PCR and opportunistic infections in immunocompromised patients. We have seen a lot of these misses for Legionella, sometimes Mycoplasma. It is not mandatory that you can get it, but if somebody is not improving, then you have to keep this thing in the mind. Radiology, chest X-ray is important modality, but I think there are some 10-20% of chest infiltrates are missed in chest X-ray, so you need to get a CT chest, which would be high resolution CT chest. So the guidelines for United Arab Emirates usually say that you should consider getting a CT while waiting for COVID-19 PCR. Now, why it is important? Because sometimes you can get a positive CT and negative PCR. So what are the chances that positive CT and negative PCR? So probably you need to repeat another PCR to confirm that he or she is negative for COVID PCR. As we all know, the asymptomatic people can be isolated at home, and like mild, moderate, and severe patients should be admitted to the hospital. We should implement standard contact droplet precautions, consider recommended active managements from moderate to severe patients. I think it's very important to understand that we should not use unnecessary antimicrobials because we have seen a lot of use of antimicrobials during the period of COVID, which increased the resistance, and antimicrobial stewardship principles should be applicable over here. Positive COVID-19 case management in outpatient and in emergency department. All patients with COVID-19 positive should be assessed at least for CBC, renal functions, CRP-D dimer. And remember, azithromycin is not indicated, as we were all thinking before, azithromycin, doxycycline. At one point in time, we were giving almost every patient positive for COVID, doxycycline and azithromycin. And also, we need to think if the person is coming in OPD or emergency department, if the patient is clinically stable, he can home isolate at home. But if the patient is more than 60 years old or having comorbidities, then we should start antiviral. That would be favipiravir for 7 to 10 days. And we can consider giving supplements like vitamin C, D, and zinc. I'm sure all are well aware of this. And if the person is more than 60 and comorbidities, we should also check a D dimer. And if it's above 2, we should be thinking about therapeutic or prophylactic anticoagulation. And any patients with comorbidities to be followed 3 days after teleconsultation, which we usually did maybe 6 months, 1 year ago. And patients should be assessed for eligibility of monoclonal antibodies. Now I'll come to monoclonal antibody in a few minutes. Severity of disease, as per our Emirates guideline, is mild, moderate, and severe and critical disease. So mild disease is individuals who have any kind of various signs and symptoms of COVID-19, which includes fever, cough, throat pain, malaise, headache, muscle pain, without shortness of breath, dyspnea, or abnormal chest X-ray. Moderate disease individuals who have evidence of lower respiratory disease by clinical assessment or imaging, and the saturation oxygen more than 94%. So moderate disease is still saturation is fine. Severe disease is respiratory rate of more than 30 and the saturation is less than 94. Critical disease, as we all know, is respiratory failure, septic shock, and multi-organ failure. So what are the tests that we need to do? Baseline test as mentioned before. And then once the patient gets stabilized, we need to repeat the PCR after 5 days of positive swab collection. Thereafter, to see the patient if he's becoming negative every 72 hours. We should image like the recommendation in UAE is doing HRCT first and then followed by a chest X-ray. And then we can repeat more frequently in patients who are critically ill. So what are the prognostic factors for COVID-19? As we said, age more than 55, pre-existing pulmonary disease, chronic kidney disease, diabetes, history of hypertension, cardiovascular disease, severely morbidly obese patients. Category 2, if the respiratory rate is more, if the heart rate is more, and oxygen saturation is low. And category 3, if the D-dimer is high. If the D-dimer is high, we all know there would be a high morbidity and mortality in that patient. CPK is high, there would be a higher mortality. CRP is high, most likely the patient would develop a severe disease. Elevated troponin, admission, as we discussed in the prior lecture from Spain, that if there is absolute lymphocyte count is less than 800, that would be a problematic. And if the ferritin is high, that would be also a category 3. Treatment options, we have several treatment options. We have to rule out pregnancy first before starting favipiravir because potentially it is teratogenic and it is absolutely contraindicated in first trimester. But luckily, the other medication that would be remdesivir is probably we can give in pregnant patients. So COVID-19 URTI without pneumonia, we can refer the patient for monoclonal antibody infusion centers and for high risk and symptom less than 10 days, or we can give them favipiravir. Confirmed COVID-19 pneumonia, which would be mild to moderate. Patient who does not need, that would be in bold and, underline that they don't have, they are not needing any supplemental oxygen. They should be considered for monoclonal antibodies. Anybody who is requiring oxygen, they are not candidates for monoclonal antibodies. Or we can give them favipiravir. Along with monoclonal antibody, you have to give them favipiravir. With confirmed COVID-19 pneumonia, a patient with saturation less than 94, as I said, they are not candidates for monoclonal antibodies. But then if the patients are ventilated or have moderate to severe pneumonia requiring oxygen, we need to give them remdesivir plus dexamethasone we have to give them. So dexamethasone is only proven drug these days, and also there are a couple of more medications which are proven to decrease the morbidity and mortality, including remdesivir and others. So dexamethasone is very, very important medication in moderate to severe disease in COVID-19 patients. So monoclonal antibody after referral to ID, internal medicine, I'm sure internal medicine has seen a lot of COVID-19. So sotrovimab, what is authorized use and indications as per our UAE, Abu Dhabi and Dubai Health Authority, is mild to moderate disease without needing of oxygen. And what it does, it decreases the progression to severe COVID-19 disease, including hospitalization or death. And it is not authorized for the patients who are hospitalized due to COVID-19. As I said, it's bold and underlined who require oxygen. Worse clinical outcomes if it is administered in hospitalized patients who are on high flow oxygen or ventilation. So what are the high risk for progression for COVID-19 patients? Older age, more than 65, more high BMI, pregnancy, CKD, immunosuppressive disease, cardiovascular disease, chronic lung disease, sickle cell disease, neurodevelopmental disorders, and genetic and metabolic disease. So the message for this slide, you can use a higher dose of dexamethasone if the patient is morbidly obese. So this is a case, 41 years old male with no significant past medical history, was vaccinated 6 months ago, with presents 5 days history of cough, fever, fatigue, shortness of breath, and room 88% of oxygen saturation on 3 liters of oxygen. This is his chest CT. He develops fever, high CRP, lymphocyte count less, oxygen requirement. So what would be the next treatment for this? So this is possible cytokine storm. In this cytokine storm, we see high CRP, we see high inflammatory markers. And how you will diagnose this, you can do IL levels, IL-6 levels, and then you can diagnose this. And we usually give tocilizumab in this kind of people. The criteria is if the patient is not improving and there are signs of multi-organ failure, high inflammatory markers, high CRP, we are thinking that probably patient is getting cytokine release syndrome. Dose is 4 to 8 milligrams depending on the body weight, and maximum dose is 800 milligrams. So this is probably the schematic diagram of getting monoclonal antibody. I think everybody probably is aware how to get this antibody. We have to see the use of oxygen if the patient is not using oxygen and it is more than 65 years of age. And all these things which I mentioned earlier, you can use a monoclonal antibody in that patient. Importantly, you have to understand there might be a superimposed infections in patients who have COVID-19 infection. As I mentioned earlier, you have to keep your mind open that they might develop some other infections. Differential diagnosis could be bacterial pneumonia, for which antibiotics can be prescribed. As we said, I think we got higher rate percentages of superinfections, the pandemic which appeared in China, Spain, and New York. So the high percentages are 58 to 95, 74, and 65%, respectively. So in summary, what we can say that among patients with COVID-19, this is IDSA guideline panel recommends against hydroxychloroquine azithromycin that we also know. Lopinavir, ritonavir, we should not use. Among hospitalized critically ill patients, COVID-19, the IDSA guideline panel recommends dexamethasone. Critical illness is defined patients with mechanical ventilation or ECMO. Critical illness includes organ dysfunction, seen as sepsis, septic shock. In COVID-19, the most commonly reported end organ dysfunction is ARDS. That's very important. Among hospitalized patients with severe but non-critical COVID-19, the IDSA guideline panel suggests dexamethasone rather than non-dexamethasone. In hospitalized patients with severe COVID-19, IDSA panel suggests remdesivir. This IDSA was published in 4/11/2020 and last updated recently in October. In hospitalized patients with severe COVID-19, as I said, IDSA recommends remdesivir rather than no remdesivir. And patients with invasive ventilations or ECMO, IDSA panel suggests routine use of remdesivir. In the patients on supplemental oxygen or ECMO, the panel suggests also you can increase the duration of remdesivir from 5 days to 10 days. The last slide, in patients with COVID-19 admitted to the hospital without the need of supplemental oxygen, saturation more than 94%, the IDSA panel suggests against the use of remdesivir. So against the use of remdesivir. So with this, I end my presentation, and I think I did it on time, and I'll be happy to take any questions.
Thank you very much, Dr. Aqeel. We don't have any virtual questions. If you have any questions, please come forward to the microphone.
Thank you, Dr. Aqeel, for the comprehensive presentation. Just I do have two questions. For venous thromboprophylaxis, whether we have a time frame or duration, fixed duration for COVID patient, and if we can prescribe that for mild cases in outpatient patient session or just limited to hospitalized patient.
I think anticoagulation, as I said, if the D-dimer is more than 2, then you have to think about anticoagulation. Then you probably need to find out to admit the patient and give anticoagulation. I think there are some researches going on as an outpatient rivaroxaban or oral anticoagulation, but still in the loop. In the lineup, and then we don't know. But I think if the patient is having a higher D-dimer, he's a candidate for getting admitted and getting anticoagulation. Yes.
And for how long?
How long? That's a very interesting question, until he gets better, maybe the severity of the disease gets better. And we monitor this D-dimer twice a week or once a week or every 2 days, and we see if it's decreasing, then we can discontinue. But remember, the experience we are having, probably you need to give some kind of anticoagulation as an outpatient. Like if you want to give some aspirin, I think in US they are giving aspirin 100 milligrams daily for maybe a couple of months or so. So that's what they are doing.
Okay, just one more question regarding the antiviral treatment. We are aware that the earlier the better, and the recommendation is to start it in the first few days actually of presentation.
Sorry?
For the antiviral treatment, remdesivir, for example.
Yeah.
So the earlier of usage of this one, the better.
Yeah.
And the recommendation is to start in the first few days actually of patient presentation. However, most of the patient actually I'm receiving would come maybe after 7 days, 10 days, with some sort of persistent symptoms or mild complication. And we do have a still excellent result for using the antiviral treatment for such a patient. So I'm not sure if this recommendation is still valid.
Actually, I think you are very right. Some people don't show up early. So 7 to 10 days, it's not effective. The recommendation is after 10 days, probably the remdesivir would not be useful. But coming back to the clinical scenario, if you see such kind of a patient, probably you will not stay away or shy away giving of remdesivir. I would still give it, if probably 10-20% benefit to the patient. I don't know, the panel probably would give it, I think, rather than not giving it.
Yeah, because actually my own personal experience with that is that we do control the symptoms actually with usage of this one. However, for the earlier 7 days, no response. So this is just my recommendation about this one.
Yes.
Okay, thank you very much.
Thank you. Okay. Next question,
My
please.
question is for the use of procalcitonin and trying to avoid unnecessary use of antibiotic. How useful is that, and what's the strategy you follow when you try to avoid the antibiotic, like for presumed bacterial infection?
Actually, the initial lab workup includes procalcitonin also. So if you can check procalcitonin initially, if it's negative or less than 0.01, then you don't need to use any antibiotics. And then you can repeat as the clinical deterioration or clinical improvement of the patient. If the patient has septic-like picture, if the patient is clinically deteriorating, if the temperature is high, if the secretions are high, if the patient is not improving in spite of giving appropriate management, then you are thinking out of the box that probably he's getting some bacterial infection. And sometimes procalcitonin might lag behind. So you might have to think about giving some antibacterials. Procalcitonin is very important marker of getting whether it's an infection or not. So I would probably still think getting procalcitonin before giving any antibiotics, but you can still give first shot of antibiotics and then wait for procalcitonin.
One more question. Now with the influenza season coming, and if we receive SARI patients where we are not sure, how we empirically target both if it is the possibility that either or both are
Actually,
with the patient?
That's the similar kind of a question that has been asked multiple times. Actually, it's very important question. The person who does not have a COVID, when it's anybody who is coming with influenza-like symptoms, you have to check for COVID. If somebody does not have a COVID, you are thinking of influenza or respiratory syncytial virus like RSV. Then what you have to do is you have to do a lower respiratory tract panel that would include influenza, not influenza, that will include RSV and the other viruses that are probably 8 to 10 viruses. Then still you have to check for influenza because this would be a season for influenza. But anybody coming with flu, because it's a pandemic, you need to check COVID also.
But as like a empirical, would it be useful just to put him on remdesivir, which broad spectrum antiviral can cover both,
No,
or you have to be
remdesivir-
specific?
No. I think remdesivir probably will unlikely cover influenza. And remdesivir is IV, by the way. It is not oral. So you cannot give empirically remdesivir because we have given millions of patients remdesivir and it's not a very cheap medication. No, I would not give empirically. I have to get diagnosis first, and influenza test does not take a long time to come back, and sensitivity and for the PCR is pretty good. So I would probably shy away or stay away giving empiric and COVID medications because these are potentially toxic medications.
Thank you.
Thank you.
Thank you very much, Dr. Aqeel.